This is an unedited video of a small pupil. I'm using a marker. It's a 1.25 millimeter marker to mark the limbus and 1.25 millimeters into the clear cornea, so that works as a template that can let us get a perfect main incision 10 times out of 10. One can see the groove on the limbus, make a partial thickness cut there, enter with the 2.4 millimeter blade, depress at this 1.25 millimeter mark, so we get a perfect 1.25 to 1.5 millimeter long main incision every time. So I just put in intracameral anesthetic. That was 1% lignocaine. Now in goes viscoelastic. You see, this pupil is just about 5.5 millimeters. If one can keep the chamber well pressurized throughout surgery and have no sudden decompression, we'll be able to complete the surgery very comfortably. The rhexis is made using the pupillary margin as a template. Go just about under the pupillary margin and maybe about 0.5 millimeters outside under the pupillary margin. Keep the tearing edge flat and don't let it bunch up. That way you would get excellent control over the anterior capsular flap, making the rhexis perfect, circular and central. One has to remember, before doing a hydrodissection, it's very important that we let out a little bit of viscoelastic, go just under the anterior capsular edge, lift it up and inject. If you don't get a fluid wave, using the knuckle of the hydrodissection cannula, just decompress a little till you get the hydrodissection wave. If the wave is achieved in the perfect dissection plane, we would be left with almost nil cortex to remove at the end of surgery. The first step would be to remove all the cortex and epinucleus from the area of the rhexis. So we go approximately 1 millimeter into the cataract. Right under the subincisional area, just under the area of the rhexis, make a punch, enter in, do a chop. That way the chop goes end to end and it's complete at one go. The second chop is done after a partial rotation of the nucleus, and if one can take out that small little sliver of the nucleus first, that gives us a lot of space to maneuver. This is a totally unedited video. Chops are done in situ. Make small chops. Stay as much as possible inside the capsular bag. Stay in the center so that the iris is not damaged anyway. You don't get the iris pupillary margin into the phaco tip. Wait for the pieces to come to the phaco tip. Patiently fold, then emulsify. You would find here at the end of surgery, since the hydrodissection was done in the perfect plane, there is absolutely no cortex to remove. It's completely clean. That saves you both time and the work that has to be done to do a cortical removal. Sodium hyaluronate is injected to blow up the capsular bag, and the IOL is injected into the bag. As it unfolds, one can use the IA cannula itself to nudge the lens into the capsular bag as it unfolds now. All the viscoelastic is removed. Any small amount of cortex as a subincisional area is also removed. One has to go under the lens always to remove any trapped viscoelastic there. That goes a long way to prevent postoperative intraocular spike as well as preventing postoperative inflammation. Lens is centered. The surgery is over. The main wound is hydrated with PSS. Diluted moxifloxacin is injected through the side port into the anterior chamber. Anterior chamber is checked for the proper IOP, and that's the end of surgery.